Next topic is the optimal use of MMF in transplant and therapeutic monitoring. It will be delivered by Dr. 𝐒𝐮𝐤𝐚𝐧𝐭 Das. He is the senior nephrologist from Amri, Bhubaneswar. Dr. 𝐒𝐮𝐤𝐚 Das, please.
Good morning, everyone. So, having had a discussion on steroid-free immunosuppression and how we can go for withdrawal of calcineurin inhibitors, I will be talking about taking forward this morning session on individualized immunosuppression, the third most important element in the immunosuppressive regimen, that is MMF. Unfortunately, this topic is a little more offbeat, and it's not something that a clinician comes across in everyday use, the therapeutic monitoring of MMF. So, starting my topic, optimal use MMF in transplant and its therapeutic monitoring. My presentation will go on the basic headlines. We will touch upon the mechanism of action, then go into the pharmacokinetics and pharmacodynamics, then have a look at whether one dose fits all approach is good or we need to go for controlled concentration dosing and the different methods of concentration controlled dosing before we touch upon systematic literature reviews and see if we can come across any final takeaways and conclusions. So we all know mycophenolate mofetil is the metabolite of choice in immunosuppression regimen in transplant patients. It is a prodrug and its active moiety is mycophenolic acid, which is available. The prodrug is available either as an ester prodrug or an enteric coated formulation or ECMPS. These drugs are derived from various species of the penicillium fungus. How does it work? It works as a rate-limiting step in the de novo biosynthesis of guanosine nucleosides by inhibiting the enzyme IMPDH or inosine monophosphate dehydrogenase. Now, inosine monophosphate dehydrogenase type 2 is the enzyme which is most specifically inhibited by this drug. And this is a very important enzyme because it is important for de novo biosynthesis and which is more importantly taking place in lymphocytes. Most other cells in the body have a salvage pathway. So it's the potent cytostatic effect of MMF on lymphocytes that is important and the principal mechanism of action. It has got certain other elements to its action. For example, it induces apoptosis of activated T lymphocytes. It also, by depleting guanosine nucleotides, it somehow suppresses the proliferation and migration of neutrophils, lymphocytes, as well as monocytes, the drugs, the cells that are responsible for aggravating an ongoing resection. So it has a protective effect against ongoing resection. And also another very important aspect of this drug is that it has a preventive effect on the development and progression of proliferative arteriopathy, the critical pathologic lesion in chronic resection. So these are some of the very important aspects of this drug. Now, how the metabolism takes place. After its absorption, it's rapidly and completely, after its ingestion, it's rapidly and completely absorbed and undergoes pre-systemic deesterification to the active moiety, that is MPA. MMF directly cannot be measured in the blood, and it is MPA which is usually measured. This drug has two peaks. The first peak occurs followed by equally quick drop, and a second peak with a variable time occurs due to enterohepatic reduction, recirculation, the main metabolites of MPA. So the contribution of the second peak, of course, is around, it happens around 6 to 8 hours after the first peak, and it has a contribution of around 30% towards the total drug levels in the body. Now, some of the drug that escapes metabolism in the intestine goes via enterohepatic circulation to the liver. Now, for those of us who, we are well aware of enterohepatic circulation, just to re-emphasize, enterohepatic circulation is a term that refers to a cycle in which a drug or any metabolite is excreted in the bile and then reabsorbed from the intestine either as a metabolite or conversion back into the parent drug. So enterohepatic circulation is a mainstay in the metabolism of this drug. Now, this drug, after getting to the liver, gets converted into MPAG. Okay. So it gets converted into a metabolite MPAG. It's the glucuronide metabolite is important as it is converted to MPA through enterohepatic circulation. Now, UZT-A19, UZT-B27 are the two major enzymes contributing to the metabolism of MPA. It is important to understand that these two enzymes are very important as far as the metabolism is concerned. These two enzymes, if they undergo some kind of gene polymorphism, then there is definitely, what happens if these enzymes undergo gene polymorphism, then some patients will be rendered to have early rejection because of this gene polymorphism. So there are various things that can impact the drug labels. That is why it's all the more important for us to switch over or think about switching over from FD regimen to a therapeutic drug regimen or therapeutic drug monitoring. And those are important aspects. For example, the chronic kidney disease or a patient having allograft dysfunction. When there's stable kidney function, there is a very good correlation between the total and unbound aspect elements of MPA. But in case of chronic kidney disease, there is a displacement of MPA from MPAC fraction, and that causes the undue rise in MPA levels. And there is also another important aspect that has to be kept in mind. Hyperbilirubinemia can also lead to displacement of MPA from protein binding with an elevation of free MPA fraction. Therefore, severe hepatic impairment is another important impediment. There are certain drugs that can impair or cause an impediment in the metabolism of the drug. Those are ferrous sulfate, the contribution of intrahepatic circulation by oral cholestyramine, and don't forget that cyclosporine also affects MPA intrahepatic cycle. And in early post-transplantation, when we are using high dose of prednisolone, that can also significantly alter the metabolism of MMF. So now we come to the next aspect of our presentation, that is the role of therapeutic drug monitoring. For all drugs, the concentration at the site of action is more directly linked to the drug effect than the dose. But for certain drugs, the concentrations can vary widely, basically because of two factors. One is the extent of absorption, and other one is the rate of elimination. So precision dosing of an immunosuppressive dose of immunosuppressive drug requires an understanding between intra-subject variability. Traditionally, we have been using MMF as a one dose suits all, despite the evidence since the time of development about the role of concentration control dosing. We understand that the fixed dose regimen can show a wide intra-subject variability of more than 10 times. Sometimes the labels or the area under the curve labels can be less than 10, or sometimes they can be more than 100. So as I was just stating, the relationship between unbound and total MPA concentration is linear under most normal physiological circumstances, but this is not the case in certain settings such as hypoalbuminemia and severe renal impairment. Because the metabolism of MPA is complicated, there is a nonlinear absorption kinetics, there is intrahepatic circulation, and there is plasma protein binding. So why it is important to understand the therapeutic drug monitoring of MMF? Because the importance of this drug, it has got certain toxicities. We all understand it has got a hematological toxicity. So we have to be very meticulous. If there is a certain amount of drug which can give us the therapeutic benefit without causing undue toxicity, that is one aspect. And second is, of course, a less amount of drug in the blood or a low than the desired level of the drug can predispose an individual towards development of donor-specific antibodies. So MPA, through its mechanism of action, can protect against the development of donor-specific antibodies. That is why we have to be very specific if we are giving the right amount of drug or not. There are different methods of therapeutic drug monitoring. One, the TDM word here will be used basically for the C0 estimation, and the other one is the target concentration intervention that typically addresses towards area under the curve in this case of patients. Now, these two different ways of monitoring, then which one is better? When we talk about therapeutic drug monitoring or the C0 label, that is, we all understand we have been doing in case of CNIs, we're doing it in case of cyclosporine, we have been doing in case of tacrolimus. There is another way of therapeutic drug monitoring, that is target concentration intervention in case of MMF. This provides a optimal point of balance between benefit and toxicity, and the dose required that can be directly calculated from target concentration and clearance. How do we measure this drug labels or the area under the curve? I will come to it in subsequent slides. So we will go to various systematic literature review, how they have focused, how they have taken several studies into consideration, and have taken into consideration some of the largest randomized control trials. Now, Meds et al. Have done a study which has shown that if we look at 5 randomized control trials, there are 3 randomized control trials which have taken multi-target RCCT, ApoMegar, and ApoERA trial, and the 2 other trials which have been taken into consideration taking TDM. Now, when we look at the trials that have used TCI as the therapeutic or target concentration intervention, then they have reached a point where, if I can skip through a few slides, to come to our discussion, then TCI reveals a statistically significant and clinically important benefit of the area under the curve has a significant benefit over the certain single point estimation of the drug. These are some of the other papers, other studies which have suggested to the same finding. What are the different approaches? One is the C0 approach, and other one is how do you measure area under the curve? You can go for a full PK modeling, or you can go for limited sampling strategies. For this limited sampling strategies, various mathematical formula, which is under the typical subject of clinical pharmacology, they have devised several formula by which you can measure serial samples, or you can measure samples at 20 minutes, 1 hour, or 3 hours to reach a conclusion. Now, you can also measure IMPDH labels, which is of course at an experimental level and still not in clinical use. The KDIGO also supports that, even though it's not very conclusive, but
Sorry
KDIGO
to interrupt,
supports
sir.
that
Requesting
C0
you to
labels
conclude
are
the
less,
presentation, please.
I'll need just 1 minute because there was a disturbance in between. Yeah. So the C0 labels are of course not conclusive. Therefore, they have suggested that the area under the curve will be a more predictive and will more be better in terms of clinical outcomes of this drug. The proposed therapeutic window for MPA area under the curve is 30 to 60, which is restricted to early post-transplantation period. And so, if we come at the summary recommendations, whether it's in adult kidney transplant recipients or in pediatric kidney transplant recipients, the drug label, that is the area under the curve that is desired, is 30 to 60. There is no evidence for specific area under the curve target beyond first year after transplantation, and there is no effect of, there is no evidence in favor of using MPA C0 to adjust dose labels of MMF. So what is the final conclusion? As I just stated, MPA AUC can be a valid biomarker for drug exposure, more directly linked to the drug effect than mycophenolate dose. And the imprecise one dose suits all approach with mycophenolate mofetil should come to an end, or should it come to an end? Have we reached a conclusion? Because despite several papers and 20 years of this drug, we still do not have a definite conclusion at this point of time. So the floor is open for discussion. Thank you for a wonderful listening.
No question. Thank you very much, Dr. Sukant.
One more aspect. Thank you all for such a wonderful response to my book, A Disrupted World, which has crossed a few thousand copies on Amazon. Thank you, and keep blessing me. And those of you who have not read my book, I request you, please get your copies, read it, and give your wonderful comments. A Disrupted World, which is effect on the pandemic of COVID-19 on geopolitical and medical scenario of the entire world. Thank you very much.